webinar and begin our call together. Good morning, everyone, and welcome to today's webinar. Substance Abuse Prevention is Suicide Prevention. My name is Kelly Hendricks, and I am with Prevention First, and I will serve as one of today's organizers for the webinar. Due to the quantity of callers on today's webinar, all attendees will be muted throughout the entire presentation, and this really will allow us the least amount of distractions as possible on the phone line. But we do want your feedback. So if you have questions, please go ahead and enter those into the questions field of the GoToWebinar navigation page. And we'll actually watch those and make sure we bring those to the attention of our presenter or assist you with any technical difficulties. I also wanted to let you know that today's webinar is being recorded. A couple of housekeeping items before we begin. I sent out yesterday a PowerPoint that will be the same as what you view today, so you have that and you can follow along with that and make notes on it. For those of you who registered yesterday, I sent out that PowerPoint today. If you haven't received the PowerPoint and there's just a couple of people where it bounced back, I'll work this afternoon to make sure that you do get a copy of that PowerPoint. CEUs are being offered today, but you do need to have a Prevention First account for those. So this isn't not a hard thing to do. Your certificate will actually be housed in your Uconnect account, and it's then accessible to you to print out sometime around mid-November. If you registered for this webinar through Uconnect and also through GoToWebinar, you don't need to worry because that certificate will be added to your account in mid-December. Now, if you're unfamiliar with Uconnect and you don't have an account, again, this is a really easy step that will allow you to get those CEUs. So you'll simply need to go to our website, and that's on your screen at this point. It's www.prevention.org. And you'll see there's a large yellow arrow, and anywhere on any page on our website, there will always be a little icon that looks like a person that says log in or register, and you would simply click on that, and it'll take you to a few questions so you can create a password-protected account, and we'll be able to add your CEUs, and you can go in there and print those out at any time. Now, if you're going to be creating a Uconnect account, we ask that you create that by December 1st so we can then take the time necessary to go in and add those CEUs to your account. Later this week, we'll also be sending out and asking you for some feedback regarding the webinar, and that'll be through SurveyMonkey. So you'll get that SurveyMonkey link. It'll ask you to complete a short evaluation, and we certainly hope you'll take the time to complete the survey and provide us with your feedback about today's presentation. So thank you for spending your morning with us. And I'd like to welcome Jennifer Martin, who's the project coordinator for the Youth Suicide Project, to the Illinois Department of Human Services. So welcome to the webinar, Jennifer.
Great. Thank you, Kelly. And welcome to today's webinar. I am Jennifer Martin, the Suicide Prevention Project Manager for the Illinois Department of Public Health, and we are pleased to collaborate with the Illinois Department of Human Services, Bureau of Positive Youth Development, and Prevention First to host our speaker from the Suicide Prevention Resource Center and provide this training to those in the substance use prevention field. This is one of many strategies we're being implemented as part of our department's statewide suicide prevention efforts. And I have included my contact information in the chat, so if you would like more information about our efforts, please feel free to send me a message, and I'd be happy to share details about our activities. Also, as a state who receives funding from the Substance Use and Mental Health Administration, we are asked to promote the National Suicide Prevention Lifeline, and so you'll see that number in the chat box also. And at this time, I am asking each of you to go ahead and take your cell phones out and program that number into your contact list. And the number is 1-800-273-TALK, which is 8255. And this is a number anyone can call, whether you are in crisis or if you are concerned about a loved one. This is a great number to have on hand, so if you encounter someone in your professional or personal life, then you have that number easily accessible. As I mentioned, we're excited to host the webinar because we understand the importance of suicide and substance use prevention fields aligning our efforts to promote healthy individuals and healthy communities. And we also understand that the needs of those in the prevention field are different than our clinical colleagues, which is why this webinar has been tailored to speak directly to those working in prevention. So if during this webinar, if there's anything you want more information on or we didn't cover, please make a note and share it with us in the evaluation you'll receive later this week. And we'd like to serve as a resource for you and provide additional resources in the future, so your feedback will be very beneficial. Also, I'd like to mention a separate training is being planned for the substance use disorder treatment providers in the spring. We'll be sure to share that information along with you about the training so you can share those details once they're finalized with your colleagues. We did have actually also a question about just some of the statistics here in Illinois for suicide. We do lose over 1,000 people each year to suicide, and just under 10,000 are treated by our hospitals. And that's not counting those that attempt suicide or have suicide ideation. And so this is a big public health concern, and we are, are spending our time addressing the topic of suicide prevention, and this is one of our strategies. So now it's my pleasure to introduce Lori Davidson, the Manager of Provider Initiative Programs at the Suicide Prevention Resource Center. We've had the pleasure of collaborating with Ms. Davidson over several of our projects, including a training we've hosted with institutions of higher education on promoting student mental health and preventing suicide on campuses. Ms. Davidson has managed programs supporting state, local, and college alcohol and other drug use and abuse, mental health, and suicide prevention since 1998. She's a Senior Project Director at Education Development Center, which is an international nonprofit that manages the Suicide Prevention Resource Center on behalf of the Substance Use and Mental Health Administration. I also add that Lori has a master's degree in counseling. So thank you, Lori, for providing this educational opportunity to our professionals here in Illinois, and I'm happy to hand the discussion over to you.
Thank you, Jennifer. And I do believe we're having a little bit of a technical glitch, which I'm going to attempt to resolve while I'm talking, which should be really interesting. I think I've lost my go-to screen, so I'm going to, while you all bear with me, I hope, go back into my reminder, click on my link, and rejoin in such a way that will allow me to share my screen with you. But now it's telling me I already have a session running, and so Kelly, we need a quick and dirty workaround here, which I think is going to involve you sharing your screen and showing the slides, and I'll need to tell you when to share them. I apologize. Let me try one more thing, and that is to get out of it and try to get into it again, and then I won't waste any more of your time. No, it says I have a session running already. Kelly, do you have a thought as to how I can get my screen back?
I see that you have minimized your screen.
But I don't really? Because I didn't. If I did, I didn't mean to, and I apologize to everyone. There it is. Kelly made it magically come back. I do see it. So, hold on, everybody. I really apologize. I've actually I can't make it bigger. Why is that?
All right. It's on my screen at this point, Lori, so let me just kind of offer some technical assistance. You move forward, and I'll see if I can kind of help forward things if you need them.
Why, thank you. Do you want to put up my slides while I try to make my, if you wouldn't mind? Great.
All right.
I should see them in a moment. I think what Kelly's trying to do is get me to make my screen bigger because we were planning to share my screen so you could see the slides, but I seem to not be able to make my go-to webinar screen bigger, and I don't really know why. All right, so I'm going to press on. I want to, I'm going to be on the second slide, Kelly, when we get there. I just to introduce this topic, thank you so many people for joining this webinar this morning. I am very grateful to Jennifer Martin and Illinois Suicide Prevention for, I just did see a nice big sharing of my slides. Thanks, Kelly.
No problem.
What if I tried to, all right. I'm going to try to show my screen again.
Okay.
Do I need you? That button isn't highlighted for me right now, so I can't.
All right, I'm going to try one more time. I'm going to make you an organizer. So now you have the power.
Show my screen. Now, are you seeing my GoToMeeting stuff?
Right, I'm seeing connected to GoToWebinar screen.
And now are you seeing my PowerPoint?
Screen. It's very, 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 very small.
Of my PowerPoint, you mean?
Mm-hmm. So keep making that thing as big as possible.
I think if I do it slideshow, that means you aren't able to see it, which is strange. So here's what I'm going to do. I think that's what the problem was, if anyone's interested at all, is that I was trying to go into slideshow mode, but I don't think you can see it. All right, so I hope this is large enough for everyone to see, and this means now I should, you can see it, but I'm not seeing the controls. Oh, but I should be able to do this? Yes. Okay, thank you, everyone.
All right.
Believe it or not, I've done dozens of these things, and something like this almost always happens, although, anyway, but apologies anyway. Just to return to my original thought that about my being so thankful to Jennifer Martin for inviting me to do the webinar and for all of her support for suicide prevention, and now, of course, for substance abuse prevention issues as well. And Kelly Henricks, thank you so much at Prevention First for being a very wonderfully supportive and well-organized organizer. That is always wonderful and always makes things much easier to do. This, the title of the webinar today is meant to be maybe a little bit astonishing and provocative, but let me just explain something that's behind it. Both substance abuse, alcohol prevention, other drug abuse prevention, and suicide prevention are both very complex problems, each of which on its own requires a comprehensive, multi-strategy approach that combines both individual and environmental or systems strategies. And I don't mean to say that only substance abuse prevention will solve the problem of suicide prevention in our nation, where averaging 36,000 people die each year. Substance abuse prevention is a lot of things, and it also is suicide prevention, and I'm going to make the case for that today, that it really is actually a significant aspect of suicide prevention because of the link between the two. Now, before I go on, I want to acknowledge several colleagues that have helped over the years put this particular, actually rather unique presentation together. Jason Kilmer, in particular, who is both a faculty member and the director for substance abuse prevention at the University of Washington. And then Dave Stewart, Sheila Krishnan, and Carrie Smith, all of whom have been staff of the Suicide Prevention Resource Center at one time or another. Sheila and Carrie both still are. Dave Stewart has gone on actually to the Public Health Department in Minnesota. They have been instrumental in doing multiple versions of this presentation and really helping to refine it. Jason in particular is an expert in alcohol and other drug prevention, and you'll see when I get to them his particular contribution to this presentation. But without them, I wouldn't be able to do this for you here today. So this is going to be our agenda. Now, I want to acknowledge that there are different needs in the audience today. This presentation is designed specifically for prevention people. And as Jennifer said, I believe she said there's going to be one, although I don't know because I was busy with my technical problem, that there would be a parallel presentation for clinicians in the spring. If you have any questions as we go along, type them in the question box, and Kelly and Jennifer will triage them. If they are something that's digs deeper into the clinical part, I may not be able to answer that today, but certainly it will help inform the development of that additional webinar and will be useful nevertheless. I'm going to go through the suicide risk and protective factors and warning signs really quickly, and then move into the general relationship between alcohol and other drug use and suicide, including then a sort of a look at the effects of alcohol and other drug use on suicidal thinking, which, in fact, I'm just going to close sorry about that. The effects of AOD use on suicidal thinking may seem to be more of an individually focused piece of the presentation, but I think it really drives home, even for preventionists, what this relationship is all about. I want to look at, along with you, alcohol as a risk factor for suicide from some of the research that's been done. All of this is based on research. And then perhaps I'll be preaching to the choir in the final moments of the webinar when we talk about the impact of environmental alcohol prevention. And in particular, because I know you're all probably very familiar with environmental management or environmental strategies, but what's been super interesting is the impact of environmental alcohol prevention strategies on the suicide rates. And I think that will really bring it home for you how important this relationship is. All right. So, poll number 1. Now, this is my next technological challenge. I'm going to ask you all to share make a choice there for one of these 5 areas, and if you are someone who is other than the first 4, if you would type into the chat field what your field actually is. And looks like we're getting close to half of you having voted. I'll keep going till we're pretty close to 100%, so do put your... Now, I'm assuming you all... Kelly, they're seeing this?
Yep, we're seeing it.
Great. So I've got about 75% of people having voted. So what it looks like is what we pretty much anticipated, primarily substance abuse prevention staff, with about equal distribution across choices 2, 3, and 4, education, higher education, health and behavioral health care, and representatives of statewide agencies, and then other, although I haven't seen anyone type in the chat field the specifics, that gives us a good sense of who's here. Thanks.
Lori, go ahead and can you go ahead and push the close button, and it'll show, since almost 90% have
got it.
Actually
there you go.
finished, we'll be able to, and then share, and we'll see the results.
Share results.
There we go. That's great.
All right. Okay, good. Thank you. All right. Now, do I need to hide the results to go back? or
Right.
let's see.
To move on, you'll go ahead and hit the hide button and go for it.
All right. Great. All right. So back to, we're going to do several polls in a row, and this next one is to get a sense of what some of the risk factors are for suicide. So this question is going to ask you which of the following is not a risk factor for suicide. So again, you vote in the same way that you just did, and this one will be interesting and will help us really differentiate between risk factors and warning signs, I think. About half of you have voted, so I'll wait a few more seconds to get that number up there. Yeah, when we get to 80, about 80%, I'll close the poll. Although I'll also close it when I see that people aren't voting anymore. Looks like no one else is going to vote. So I'm going to close the poll, share results. Now this is really very interesting. You basically got this right. 43% of people who said giving away possessions is not a risk factor for suicide were correct. A prior suicide attempt is, in fact, perhaps the most salient risk factor for suicide. Mood disorders are risk factors for suicide, rather. Depression and anxiety are both risk factors for suicide. Access to lethal means is definitely a risk factor for suicide, and as we're going to discuss today, alcohol and other drug use are risk factors for suicide. All right, so let's go to the next poll, which is what are suicide warning signs. So this poll, we're asking you to say which of these are suicide warning signs. Threatening to hurt or kill yourself, increasing alcohol or drug use, seeking a means to kill oneself, or dramatic mood changes, or all of them. Which of these are warning signs? And I see just more than half are voting. A lot more people are voting this time, with 78, 79, 80% of people have voted. Let's close the poll and share the results. And indeed, you're correct. All of the above are warning signs warning signs for suicide. So I'm just going to hide those results. And so here's a summary, which is available on the Suicide Prevention Resource Center website in a document which is a primer called a primer. People pronounce that differently at different moments, on risk and protective factors and warning signs. So you'll see here that some examples of risk factors for suicide are and so the definition really is that a risk factor at the individual level, at least, indicates that someone is at higher risk for suicide. So prior suicide attempt, mood disorder, substance abuse, and access to methods of lethal means are all considered risk factors. Here are a few protective factors. We didn't get into those in a lot of detail, but at all in the polls. Connectedness, clearly the availability of mental health care, and I would say mental health care in particular that addresses suicidality in a way that mental health care often doesn't, and the ability to cope with the ups and downs of life would perhaps indicate that someone is at lower risk for suicide. And the difference between risk factors and warning signs is an important one because warning signs are more proximal. They're more immediate. They indicate that someone might right now be seriously considering suicide. And those are the kinds of things that you all were mostly right about in that poll, that dramatic mood changes, seeking a means to kill oneself, etc., including, and hopelessness is a very interesting one in that we often look to depression. It may be that hopelessness is even more salient of a warning sign in the here and now than the mere presence or absence of depression in any individual. So let's get into that relationship between alcohol and suicide after that brief overview of the risk factors. Now, alcohol use or drug use in particular are what we call proximal risk or proximate risk factors for suicide, as well as more immediate risk factors. And I'll get into the immediate piece in a little bit. A proximal or proximate risk factor means that it's a factor that this identified mental state or psychological issue or behavior was present at the time of death. And this is from some research that was done on actual suicide deaths, psychautopsy studies they're generally called. And so the frequency of occurrence here is 68% of the cases that were examined gave evidence of alcohol or substance abuse at the time of death. In the case of, excuse me, I misspoke. This study is about serious suicide attempts, not deaths. It's not a retro study, but it's serious suicide attempts. So 68% of the time there's alcohol or substance abuse involved in serious suicide attempts. Now, as a lead-in to this next interesting piece about the relationship, just wanted to review blood alcohol level. And what I think many of us, we focus quite often in prevention on 0.08 or 0.10 from a prevention standpoint in terms of the legal limit for being able to operate a motor vehicle. But it's important also with suicide and alcohol is a risk factor for suicide to remember that at about 0.06, cognitive judgment is impaired. So why is that important? Well, one of the reasons it's important is because of this condition called, or state of cognitive impairment called alcohol myopia, where an individual can't really process information and really spends a great deal more of his or her attention only to what's right in front of them at the time, and that they're not able to sift through the impelling and sort of inhibiting cues that might help them to make better decisions. So how does that really play itself out? If you imagine that that this wider part of this diagram constitutes all the given options that an individual might have, let's say if something terrible happened in their life, or even moderately terrible. In the case of young people, it's often a relationship breakup that might be problematic. And that all the options available to alleviate their pain can be seen here. But as someone drinks more and gets more and more cognitively impaired, you can see how narrow the range of options in their thought process can appear to them, such that they may end up fixating on suicide as the only way to alleviate pain, or one of several much more viable options to alleviate the pain, rather than other options that might have been available to them if they had not been drinking. Or the options are available but may not have been available to their thinking process if they were not drinking. Now, I should also disclaim I'm no alcohol, biological, chemical researcher, but let's just talk about the factors affecting absorption and oxidation of alcohol, because that affects the next effect of alcohol, and then we'll pause and see if there are some questions after that. So again, I know you mostly know that that alcohol, how quickly we absorb alcohol, really depends on what we're drinking, what it's mixed with, how fast we drink it, whether it's mixed with something that's bubbly, and whether we have food in our stomach. And for women, there is also an enzyme in the stomach that affects the rate of absorption. And oxidation is how quickly it goes out of our system. And you know what? It doesn't matter. Once you've had a certain amount of alcohol to drink, it takes the same amount of time for it to go out of your system, regardless of all of whether you may have eaten something or not. And so here's just an example. If you're at 0.08, it takes 5 hours. 0.16, 10 hours. 0.24, which is pretty serious, but still is done, takes obviously, 15 hours. And what I want you to notice here is this is generally quite a bit longer than most of us probably sleep on any given day, especially a work day. And that's exactly what I want to talk about around this, and that is the effect of alcohol use on sleep, and therefore on mental health. And I'll just say briefly that there are similar effects in a somewhat different way for marijuana use as well that I'm not going to touch on today in the interest of time, but just know that the patterns don't end up being exactly the same, but the ultimate end result is. Now, for those of you who know something about sleep, this is a normal sleep pattern. In the early parts of the night, you spend a longer time in what we would call deep sleep, shorter time, about the same amounts of time, but you're getting up into less deep sleep. REM sleep, which is when you are typically, if you remember your dreams, dreaming, starts out with a short amount and longer amounts, so that you're in a less deep sleep, you're in REM sleep a longer amount until you wake up. Alcohol, this is sort of like, okay, so last night I drank to 0.08 or 0.10, and this is what will happen to sleep when you don't have enough time to get it out of your system, is that you don't spend any time in REM sleep at all, which is considered essential. And more towards the time when you should be having shorter amounts of time in sleep, they start to stretch out. And you spend an awful lot of time not in deep sleep at all. The next night, what you're seeing is an even worse sort of pattern here with much longer REM sleep, very little sleep in these other stages, and the result is an increase in daytime sleepiness, anxiety, irritability, jumpiness. And then, let me just skip over this and show you. So if there is another additional next day where there's alcohol in the system, what you end up with is, you can see these long periods of time in REM sleep and hardly any time in deep sleep. And so that, at that point, we're at fatigue. I mean, and there's plenty of research involved that talks about the relationship between sleep deprivation and mental health, fatigue and mental health, real honest-to-goodness fatigue, not just a little bit of weariness. So let me see what's, okay. So we're going to move into alcohol as a risk factor for suicide from this, just looking at the relationship between alcohol use and mental health, alcohol use and suicide, and then the way in which sleep impacts that. But I am going to just stop because I think that Kelly has a question to ask me.
I think we have a question that would be good for everyone to hear, and the question that came was, what is the difference between a serious suicide attempt and a non-serious suicide attempt?
Well, that is an excellent question, actually, and one of the resources I'll make sure to put on the resource list that I'm going to send, that can be sent out to everyone, is a link to the CDC definitions. And there is actually, so the difference between I think the definition currently being used, a serious suicide attempt is one that results in having to get medical care. And Jennifer, if I'm wrong about that, please chime in. Whereas a simple suicide attempt might be one that does not involve needing medical care. But if it's serious, you're either at the ER or you've gone to your primary care doctor or something of that nature. And there are, yeah, thanks. I think it's very interesting to look at the CDC definitions, and I highly recommend it because there are some other very interesting differentiations between that look at intent, for example. So non-suicidal self-injury, for example, would require the determination that the person didn't intend to kill him or herself. So, so at any rate, this is something that actually is an ongoing question in the field, is how to define some of these things. I'm looking, Kelly, could you call my attention to which question?
Sure.
I see tons of questions.
Yeah, there's one that is kind of asking for some clarification, saying, did you say that the progression of sleep interruption was based on drinking each day or based on subsequent days after just one day of drinking?
Subsequent days of drinking. So drinking each of those days that I was describing. But you can see a mild impairment the first night, and then if you aren't drinking anymore, that sort of goes away. But if you have a situation where several nights in a row somebody is drinking to, higher levels, then you're seeing the sleep deprivation. Jason originally prepared that for use in talking about college students, where there's this sort of interesting cycle of stress, so-called stress, sleep, not sleeping, alcohol use, and the question, which I'll raise late in a little bit, is which comes first in all of that, and how do you address it from at least a clinical standpoint? Kelly, is there anything else I should address now before I go on?
Sure, let's see, I have one more, and then you can move on, but it was the question of, do other drugs affect sleep patterns similar to those of alcohol?
I mentioned that I know that marijuana does in a different way, but in other words, the pattern of sleep, REM sleep and deep sleep isn't exactly the same, but the end result is still irritability, et cetera, and then finally, real fatigue. Jason presents a little bit on MDMA, and through a different mechanism affects cognitive judgment. I mean, you can see where if you're fatigued and irritable, your cognitive judgment in terms of alcohol and pot are also affected, but the cognitive impairment around MDMA is sort of a direct result of the chemical action of MDMA on the brain and on serotonin receptors. And I don't have that to present, but yes, and it's something that I would be happy to get you more information about.
All right. Well, I think
yeah.
That answers the questions we have, and you can finish up your comments, and then we'll move on.
Thanks, Kelly. I just will say, to finish up on that last question about other drugs, that there's been quite a bit more research done on alcohol and its relationship to suicide as a risk factor, or else, I would have more information sort of woven in here about other drugs, but the most of it has been about alcohol. And so let's dive into that. So in one study that looked at 9 different patterns of co-occurring alcohol and mental health and as suicide risk factors, 3 in particular ended up being statistically significant predictors of suicide. One of which was alcohol along with a mental health condition. Another was alcohol with other life stresses, and a third was alcohol use at the time of death. So that's one way in which we can look at the relationship. And I think that a lot of the time, historically, I think we've tended to think of alcohol as and other drugs to some extent, but again, I'm focusing on alcohol because that's what we know more about, that people, and particularly young people, drink to cope with depression, anxiety, or stress, so that it creates a sort of an assumption that this comes first. Depression, anxiety, and stress occur. I drink to relieve that, and that therefore that could put me at higher risk for suicide. And of course that depression, anxiety, and stress are a direct risk factor for suicide, but alcohol on its own is also a risk factor for suicide, but especially so when paired with mental health issues. Now, a number of studies have looked at the way in which alcohol is a risk factor. So how is it a risk factor is really an interesting question to look at. Denise Halfors, and I don't see that I cited this properly, but Denise Halfors is a researcher who did some longitudinal studies using youth risk behavior study data, 18,000 youth from, I believe, grades 8 to 11, mainly because in time 2 the 12th graders were gone, and in a year apart had determined in her first study, at the first time she looked at it, that alcohol increases risk for depression. But then later, I'll come back to that, in another study, a different study, it was demonstrated that alcohol problems were associated with worse outcomes with respect to depression course, the length of depression, suicide risk, death by risk in general, both for suicide and other causes, social functioning, and even healthcare utilization. So, we see this effect where alcohol problems affected whether people actually were adhering to perhaps health care or even mental health care outcomes, treatment recommendations. The third bullet is from a study indicating that the greater the alcohol consumption, the higher the risk for suicide. And the final bullet here, again, is actually a repetition of the previous chart that I had put into the presentation related to 68% of suicides were, serious suicide attempts were alcohol or other drug affected. Now let's go to a fourth poll, which I think is really about this next question, which it turns out is kind of interesting, and that is, which comes first? And so this poll is asking you to choose the correct statement. So go ahead and begin voting. Depression is a risk factor for suicide. Alcohol use is a risk factor for depression. Depression is a risk factor for alcohol use. All of the above or none of the above. So about 50% of people were going just over 50%. And when we get up there, we'll getting up towards 80%. A few more people vote. We'll get up to 80%, and then I'll close and publish. So, all right. Let's just go ahead and share the results. And that's correct, all of the above. And, you know, with apologies for putting out a very obvious poll, my intent here was to show how complicated this issue is, and if all of the above are true, how do we begin to really tease out how we address this issue, really? And most of the studies that have been published have been correlational. So they'll say, yes, depression is associated with suicide. You know, alcohol risk is alcohol use is associated with suicide. Alcohol use is associated with depression. And what you end up with is, well, okay, not sure what that means, not sure how to intervene. This HealthForce study that I talked about a moment ago had 2 published articles at least come from it. The first I mentioned earlier. This second one caught my eye and was so kind of, oh, wow. And at the time I was working in college alcohol prevention, so it was especially an oh, wow moment. And, wow, how can we get administrators on college campuses to perhaps understand that alcohol really is a key variable in some of the mental health problems that they are very concerned about now on campus. So what this is data from time 2. So a year later, Denise HealthForce goes back to the same sample and looks at the same behaviors that she had looked at the first time around a year ago. And she finds, now, there are definitions for dabblers and drinkers and everything. Let's just look at binge drinkers for a moment. In binge drinkers were 4 times more likely to be depressed at time 2. What that means is the folks, the youth who were not depressed at time 1, but at time 2, a year later, were considered binge drinkers, were 4 times more likely to be depressed. For just drinkers, they were almost 2.5 times more likely to be depressed at time 2. And what should be of concern to anyone working with youth on any kind of health problems is that all of these resulted in increased depressive symptoms. Some of it, and so this, to me, seemed intuitive, although it should have seemed counterintuitive, but it really kind of made sense to me in a way. And there are not that many additional studies that really address this which comes first issue. And it may be that this is true of youth and perhaps not even something we could tease out once one is older and the which comes first becomes less clear. But the extent to which this data could inform public policy is still, I think, has not been fully addressed, and is something that I'm very interested in seeing how we might think about that. So here is another way of thinking that is a bit different, that yes, alcohol use is a risk factor for depression. Okay. So why is this important to preventionists? At some point you could say, well, this seems like it's a lot of information that might help treatment people figure out how to deal with treatment. This is why. There have been a series of articles that have pointed to environmental prevention of alcohol use as making population-level differences in the suicide rate. So, for example, the lower minimum legal drinking age, as you all are probably aware, was implemented state by state. So when they were able to do a lot of interesting research based on comparing states that had changed the minimum legal drinking age to 21 and states that had not changed it to 21 as yet. And they found that the states that had a lower minimum legal drinking age had more suicides in the 18 to 20, it was actually 18 to 20-year-olds, which seemed really important to me. In addition, researchers in Ontario, Canada, looked at the impact of per capita consumption of total alcohol on suicide, as well as a couple of other factors like AA membership, and they did tease it out as to whether it was distilled spirits, beer, or wine. They looked at the impact of these various factors on suicide, and the researchers ended up suggesting that as alcohol consumption went down, so did the suicide rate, and as alcohol consumption was higher, so was the suicide rate. And in their words, I'll just tell you what these results suggest that a 1 liter increase in alcohol consumption led to an increase of anywhere from 11% to 39% in suicides. Now, this final bullet is pointing to 2 studies from former Soviet countries, which at the end of the Soviet Union had important, astronomical levels of alcoholism and public drunkenness and all kinds of issues. And once the Soviet Union broke up, several of the individual countries, Estonia was one, and I think Latvia was another, and there was a third in 2 studies studying 3 countries. They implemented all kinds of pretty strict alcohol policies at both the country level. At the country level, mainly, they restricted alcohol availability by increasing the price, controlling prices. They increased enforcement. They restricted the availability of alcohol by restricting the production, et cetera, et cetera. Now, these are all, kind of more restrictive kinds of policies that we could ever entertain here in the U.S., and yet they mirror, many of the strong alcohol policies that many states have at perhaps lesser levels of restriction. And they found that as the drinking rates went down, as alcoholism, as a problem was solved and consumption went down, the suicide rate plummeted as well. Many fewer suicides as a result of an entire population just addressing the alcohol problem. So that was another, this series of studies is also kind of inspiring for alcohol preventionists, because now this is how we come to a kind of a theory or conclusion that alcohol prevention, when effective, is suicide prevention. When there is less alcohol being consumed, there are fewer suicides. And so let me just recap and perhaps pause again and see if there are questions.
So we have 2 questions if you're ready for those, Lori.
Excellent. Yeah, let's do that first, and then I can recap.
Okay. Because this might help as you kind of put some recapping together. Are any of the studies specific to age? I'm wondering the differences between youth and adult connections with alcohol, mood disorders, and suicide.
The studies that I just talked about are population, the minimum legal drinking age study is a study of 18 to 20-year-olds, so that specifies age. The other 2 environmental studies are the entire population. The researchers may have data on age. I don't recall that they looked at age, but it's worth going back and looking at. Also, I think I made note earlier that the Halford study, which is the longitudinal study, is a study of youth, and therefore may or may not be generalizable to an adult population, where you can't pinpoint the time that they began drinking and what came first. Although I will say there was one study, this really small study that I found, I think it was Helzer, who recruited a relatively small sample of men from a bar, adult men from a bar, and had them dial in on a phone, using the keypad, phone keypad, every day, dialed in their alcohol consumption, how much they had to drink, and their anxiety level. And, so what we would expect is people would drink more when they're anxious. And the way in which they analyzed the data was in time chunks, but what they ended up coming up with as a conclusion to this study was that that was not the case, that alcohol use predicted next day anxiety. Anxiety didn't predict next day or same night alcohol use. Now, when we stop and think about this, it actually does make sense. When someone drinks the night before, goes to work, has maybe had a little bit too much to drink, things might be off in the sense of, maybe if cognition is off, for example, if you didn't sleep well, everything isn't quite coming together, and you get anxious. So this is another one of those sort of, interesting counterintuitive, which actually makes counterintuitive things that make sense. But as I said, given the differentiations from those 2 studies, 2, 3, 4 studies that involve environmental strategies, only the MLDA article teases out age. Are there any other questions?
Okay, we have one just kind of on some clarification for the Halford study. Was that college age?
No, it was grade 8 to grade 11.
Grade 8 to grade 11. Okay, so not quite college. Yeah. We've had one person ask for some resources. So we've, based on some of the studies that you've mentioned, so if you could add those maybe to your resource list that you're developing, I think that will be helpful.
Yeah, I have a references list that has those studies on it that I wanted to hold and add to the list anything else that people might want. And then send it out.
And then, let's see, the last question at this point is, can you define a little bit more specifically what is a sex gambler?
Oh, I think I actually have that definition, but I don't have all the definitions in my notes for the presentation, but I happen to have that one. Everybody wants to know what that one is. So the definition of the researchers was that they all had sexual intercourse but few sexual partners and low alcohol, tobacco, or other drug use. So, because you notice that they also put together alcohol and sex dabblers, so that would be people who have more than low alcohol use plus a few sexual partners.
All right, I think that answers the question.
Yeah, but the research article, the article does spell out the definitions for each of those. Okay, so just to recap, what we've looked at alcohol constricting thinking, and at least one way or two ways in which it may do that. We've looked at what researchers have found about alcohol use as a risk factor for suicide, both proximal and distal. And we've looked at the idea that in adolescence, alcohol may precede depression. In other words, it may not be a self-medication for depression model, but rather depression following alcohol use. We looked at a few studies that strongly suggested that changing the alcohol environment may reduce suicide deaths. And so what we're going to look at next is the proven framework that there is for reducing alcohol consumption and consequences, which one could hypothesize if that framework were to reduce additional alcohol consumption rates, that it may have an impact on suicide rates. So, I mentioned at the beginning that people who were on the webinar were going to be coming from different professions, and we established that the majority are from prevention. So I may be really preaching to the choir here or giving you a great deal of information at this point forward that you really do already know. And so, but for those of you who are from other professions or other parts of the community and may not be aware of this or heard it in this way, I hope that this will be useful to you. And this is, and then also it'll sort of show the prevention people where my thinking is going with this, because this is to me an ongoing kind of dialogue about, how do we continue to press on environmental alcohol prevention as a proven strategy for reducing alcohol problems, in addition to suicide as well. So basically, so here's the 101. Environmental prevention uses policy interventions to create an alcohol environment that promotes safe, healthy behavior. And research over, I've got to say, the last 30 years has really pretty strongly demonstrated that these types of policy measures work. And they, in particular, reduce the problems associated with youth drinking. For example, I have a few examples here, and then we'll go on to a few more slides. So increasing alcohol taxes and reducing discount drink specials substantially reduced heavy and hazardous drinking among college and high school students in one study. Now, let me stop myself a moment here and remind myself and all of us that, again, substance abuse prevention or alcohol prevention, since we're looking at that specifically, requires multiple strategies, both environmental and individual, but even within the environmental category requires multiple strategies. And so this first example actually points to that they used a two-pronged strategy, alcohol taxes and reducing discount drink specials. So let's just remember that there's no silver bullet in terms of alcohol prevention, and that this is always going to be, and that's the beauty of some of a lot of the research in alcohol prevention. And some would say the challenge is that often it's communities that implement multiple strategies and then study the outcomes of those, and those have been have provided a lot of useful information. So here's another example. Decreasing the number of alcohol outlets in a community is closely associated with reduction in rates of alcohol-related youth violence. I believe there's been research also showing that decreasing the number of alcohol outlets is associated with reductions in police service calls. Increasing the minimum legal drinking age to 21, we talked about that in another context, but clearly. Let's go into a few more examples. So among the three categories of one is limiting access to alcohol. And again, you all are probably familiar, well, maybe not you all, but many of you are familiar with the use of land use ordinances or other kinds of use permits to, in particular, address the issue of the density of bars and alcohol serving establishments in a particular community or a particular area of a community. There are regulations or overall bans on home delivery. In fact, in Massachusetts, where I live, anytime I go to California and if I wanted to ship wine home, I can't, because you're not allowed to ship or mail alcohol to a home address in Massachusetts. Responsible beverage service training is huge. It's training servers in bars not to serve overly intoxicated people, to ask for identification, to offer food and water, and a number of other techniques for ensuring that patrons don't leave overly intoxicated. Beer keg registration, so that, for one thing, this has been very big on around college campuses and the kind of way to kind of restrict the number of kegs, for example, that are brought on campus. And then different alcohol restrictions at community events. I've seen studies where, in a community event that might have in previous years been marred by a lot of drunken behavior, cordoning off the area where alcohol can be served so that families and kids don't have to necessarily deal with all that, and then restricting the number of drinks that any of the vendors can sell is also another method of limiting access to alcohol. And there are more. These are some of the key ones that research supports. Then changing misperceptions or community norms. In terms of the research, looking at social marketing campaigns which address messaging about drinking versus social norms campaigns where the research is not quite there yet, but there's a couple of studies that have been may have demonstrated that if you change a group's misperception of how much other people drink, in other words, the alcohol advertising is designed to make us believe that everybody drinks, that every social situation has to include alcohol, and of course all the other sort of heinous things that alcohol advertising does, suggest. But this issue in particular of the misperceptions of how much people drink is really interesting, because the majority of Americans don't drink at all, or drink very little, drink, in healthy ways. So the idea that everybody drinks and that a social event has to include alcohol is really not in keeping with what Americans really do. So the extent to which you might be able to change those misperceptions, because what we also know is that when people think everybody's drinking, they might tend to drink more themselves. So the final of the three areas related to environmental prevention is enforcement. And enforcement, generally also relates in some ways to access to alcohol, because it does mean, that it does restrict alcohol access. But without enforcement, a lot of the laws and policies wouldn't really work. So things like compliance checks, shoulder tap programs that involve people going undercover into a bar or liquor store and trying to buy alcohol, either in a bar situation without an ID, looking really underage, or and similarly in liquor stores as well, and then citing the bar owner or the liquor store owner, or providing additional education is a strategy. Party patrols around college campuses are a strategy. Enforcing the impaired driving laws, of course. Without enforcement, we wouldn't have been able to make the inroads that we have in alcohol-related automobile crashes. Open container laws, enforcing someone not walking around your downtown area with an open container. And there is a longer list of enforcement measures. But again, what communities are often doing is not just one of any of these categories of enforcement norms or limiting access, but rather a combination of those. And I would acknowledge, and that's where we come to an opportunity for some discussion here too, is that it's challenging to put together an environmental prevention effort in a community. It's challenging to keep at it, and it's challenging to add to it. And one of the things that made me the most excited about doing this webinar was the opportunity to, because mostly I'm doing it with suicide prevention people, and the opportunity to hear from you, from alcohol and other drug prevention people, about your experiences with environmental strategies, what you thought could be done to sort of redouble our efforts around environmental strategies, and to talk about if there are barriers or challenges, what are some of the possible ways to overcome them. And let me again acknowledge that not everyone in our audience is working in prevention, but I think it would be possibly very interesting to you as well to see and hear what folks have to offer to these couple of questions. And Kelly, were we thinking we would use the chat for this? Or,
I think the easiest way, right, will be to have people just go ahead and put that information into the chat, and you can read off of that, and we'll go from there.
Yep, so if people could, if you can find your chat and your chat box and type in, let's start first with what are some of the barriers that you've seen to implementing any of these environmental prevention strategies, or if you haven't been involved, what might you anticipate might get in the way. And type your thoughts in the chat. There's more than 80 of you out there, so I was hoping we would get a whole lot of really good thoughts happening. So make sure when you send your chat that you're sending it to all entire audience. Make that selection underneath the chat box. If you're having trouble locating the chat box, let us know. I see some of you are using the question box, and I'm asking you to use the chat box, which is a different box, but let me just read some of these off. Barriers. Social norms are barriers. Money, lack of funding, limited transportation, low-level community readiness for change. Yeah, that's a big one. Unless I'm mistaken, if you open your chat box, which is different from your question box, and you'll see where it says type a message here, and then there should be a 2:, and a little drop-down menu. And unless I'm special because I'm a presenter, you have the option.
I think, Lori, I think at this point they're going to be putting all their responses in the question box, so I can read those to you, or if you just want to take a look at that, that's where you're going to see the answers.
All right, so I'll go back to that. But thanks for letting us know, Kim, that you don't have access. So social access, getting alcohol from peers and parents. Yep. That's a challenge. There are strategies for working with that. Parental support of minors' consumption, yes, that is a challenge. What other challenges, now that I've located where you guys are writing them? Who else has thoughts?
Lori, do you want me to, they're popping up very quickly. Let me read a few to you just to kind of think about. One person mentioned low socioeconomic area and not existent collaborators, so not a lot of collaboration. There's the community acceptance of underage use, meaning that it's kind of seen as that rite of passage.
Yep.
It can be difficult for those outside of the prevention field. They just don't understand the importance of reframing. They want to stick to those scare tactics and stay close to what they know and what they're comfortable with. And let me give you just a couple more because people are really putting some good stuff in here. A big challenge is getting and keeping key community stakeholders focused on these issues long enough to actually address the policy issue that's needed. And then one that I think is important is making sure that you have the right message for your target population.
Those are all great. You can save the questions, Kelly?
Yes, we can. We'll get a report of those so you can look over those.
I'd like to because, so this isn't the question the next question on the slide, but what I'm wanting to ask based on those barriers that you're talking about is this question, which may be a little bit too blunt, but I'm going to ask it anyway. I've been dying to ask a group of substance abuse prevention people this. Is there room, if those barriers could be overcome, how much room do you think there is for improvement or for obtaining outcomes that would in fact show reductions in alcohol use? Like if you could overcome some of those and fully implement a collection of environmental strategies, do you feel like we've done everything we possibly can, or is there room to do more, notwithstanding the barriers, but can we reduce alcohol use more, would you say, and particularly problem alcohol use? And Kelly, I'll rely on you again to tell me what people are saying.
Okay. So go ahead and type your responses into that question box. One person has said, I think if we were able to implement all of the strategies that we know to be effective, that would be a great impact. I think if we could remove communication barriers, we could get help for those people who are afraid to speak up. It would be substantial if we dealt with the environmental barriers. It starts from very early on with school-age interactions in the home environment. And there's always room to do more in our area. The schools in particular utilize only their programming, and they do need other types of strategies. And the last one that popped up at this time is, it just takes time, but I think you have to start very early with very young people.
Well, that's inspiring. I want to thank you for those responses, because that makes that really is inspiring. And you did start to get into the realm of possible strategies, but for those of you who have dealt with some of these barriers, could you now, for the benefit of the group, type in what some of your possible strategies are? I know people have said, well, better communication, but is there anything more specific, either in that area or some other area that you've done to try to address some of these barriers successfully, actually?
We've got one response that talks about building strong coalitions. I also see somebody commented getting key community stakeholder buy-in is important. Effective community coalitions, we're starting to hear that kind of importance of coalitions working at the community level and having that buy-in. Let's see. Also, somebody commented they work with the Illinois Department of Corrections. The offenders are oftentimes too scared to really talk about mental health needs and to be able to take away that stigma.
That's great.
And understanding kind of the difference based on what your age population is, that harm reduction oftentimes can be effective with college students. I would caution preventionists that are working under the FAP program to realize we do focus all of our attention on non-use messages.
Yeah, and from my experience working with college campuses on community and forming campus and community coalitions, and then also mobilizing state-level college alcohol prevention efforts, that's always an issue, the difference between campus messages and community messages, but that I've seen it overcome over and over again. Like there's no reason people can't work together, even though there might be a slightly different sort of take on that issue, and I'd be happy to help anybody sort of think that through. I don't know that we mentioned that I did spend quite a few years with the Higher Ed Center working on exactly those issues. Okay, so heading toward the end of our time together and sort of segueing into what some of the resources are, I'm going to go back to my slides, and thank you again for a great discussion, and highlight some resources which I know many of you, again, know about and some don't, but I've always been really impressed with the work of the Underage Drinking Enforcement Training Center. There was a time, when the alcohol prevention funding was really quite rich and coming from multiple sources, but I'm noticing that the UDL Training Center continues to be an active resource for community-based prevention. And that page there just shows some tools that they have. This is a SAMHSA document. talking about environmental strategies, and I reviewed it to create the list that I presented to you today. But what's really great about this is the examples of implementation guidelines for the various strategies that I think is worth taking a second look at. And then to dovetail with what Kelly was just talking about related to community coalitions and collaborations on the local level, actually, let me go to the next one first and then come back. Well, no, I'll stay with the one. If it would be at all helpful, and this is one of the other sort of thoughts to get across, if in fact we want to look at substance abuse prevention as suicide prevention, how can you as substance abuse preventionists collaborate with suicide prevention people? And one of the things I think about the benefit of that is that if you additionally could go to your partners and say, look, we have data that shows that substance abuse prevention can save additional lives, whether that might be a hook for you to get new life sort of breathed into some of your efforts if you had suicide prevention people join you. And this is a resource, and I know in some instances many of you probably have, but here's a resource available from the Suicide Prevention Resource Center that looks at collaborating and the different stages of collaboration between substance abuse prevention and suicide prevention people. And then a final resource as we head toward the end here is that the Center for the Application of Prevention Technologies has done a series of webinars that are, and this one especially, I think others may be archived on their website. And I participated in this with a number of other presenters to talk about mobilizing partnerships to address substance abuse and suicide. And there are specific community examples here of things that that folks in either communities or at the state level, and in one instance on a college campus, were able to do or began to do by partnering together. And so we'll make sure that a reference to that is on the resources sheet that we'll send out to you. And with that, I think we're going to wrap up. And Kelly and Jennifer asked me to remind you to be sure to complete the evaluation for this webinar. If you have any final questions, we have about 60 seconds, I think, within which to answer maybe one question. And I'll leave it to Kelly to choose that question, or if Kelly and Jennifer, you want to wrap up, that would also be good. But thank you, everybody. This has been a really, I've really appreciated your participation. Thank you so much.
Just as a reminder, everyone should have a copy of the PowerPoint that Lori was taking us through today, so you'll have that. My information is on the emails that you did receive. And for those of you who are part of the Substance Abuse Prevention Program through the Illinois Department of Human Services, I certainly encourage you at any time, should you have any questions or concerns, anything that you need to reach out to Prevention First and your assigned provider network specialist so we can help you and answer the questions that you would have or point you in the right direction. So again, we'll have a survey that's coming out soon. I certainly am so thankful to Lori for her presentation and to Jennifer for being a great connection to set this up. So I don't have any other information to share. I don't see any questions that are posted this time. So Jennifer or Lori, unless you have anything, we'll go ahead and end the webinar.
I would like to, again, thank Lori, and then also thank Kim Fernera for helping us organize this event, and to all the Prevention First staff for making this a reality. So if you have further questions about suicide prevention, please feel free to outreach to me directly.
All right, thank you, everyone. Stay warm, and we'll talk with you soon. And this concludes our webinar for the day.